Good morning and good afternoon, colleagues. It's great to be at what many of us consider the favorite event of the year. And here we are talking about a disease that we didn't even know when we last met. And I'll be discussing the implication of the COVID-19 pandemic on children living with HIV. And I'll do so by unpacking the relationship between HIV and COVID, exploring the impact of COVID on essential HIV services, as well as exploring the long-term implication for pediatric HIV. I'll also touch on the mitigation strategies and innovative solutions that have been put in place and see how we can use them to really get ready to catch up and continue the work that we need to do for pediatric HIV. I think it's fair to say that for all of us working in global health, through these 10 months of the pandemic, the concern around controlling the pandemic and saving lives has been as big as the concern for the indirect consequences on key programs such as HIV, TB, and malaria, where so much progress has been made globally, but that now risk important setback. So we've just heard from Mary that at the end of 2019, despite progress, we still had almost 100,000 children that died because of HIV, and only half of the 1.8 million children living with HIV receives antiretroviral currently. Now, that was the picture that we saw just before COVID hit the ground. And to fully understand how that picture is changing, we need to explore and understand the impact of COVID on these children and examine first the direct effect of COVID-19 infection, second, the disruption of routine child health services, and third, the consequences for the delivery of HIV services, including prevention, diagnosis, and treatment for mothers and children. And something I won't touch on, but that we should not forget, is the economic and social impact of this pandemic that we know will likely affect the most vulnerable among them, mothers and children affected by HIV. Lynn will later in the course of the workshop remind us of the clinical features of COVID in children more in general, discuss what we know and what we don't know. But I want to note that one of the things that we don't know is how COVID-19 behaves in children living with HIV, whether it's more frequent or more severe. And while more data is being generated in adults, we know that it's difficult to extrapolate that evidence to the pediatric population because both COVID and HIV are very different in children compared to adults. To solve this evidence gap, it's extremely important that we join forces and we do what we are very good at in the pediatric community, collect information together and collaborate. WHO has set up a whole platform to support clinical characterization of COVID-19 patients across population with various mechanisms of sharing data, with the desire of generating rapid reporting that can inform clinical management and policy decision, as well as inform the design of future vaccination strategies. Now, last time I checked, we only had 30 children living with HIV on this platform. And without your support and the contribution of many of the colleagues on the ground, we will take a very long time until we have a critical mass of data to be able to fully understand this problem. So I hope that many of you will be keen to share the information that you've collected in your own clinical practice, as well as the one that you will be collecting as the epidemic unfolds. Now, a clear message that is coming out of the maternal and child health community is that disruptions are affecting essential services, and the estimated indirect effect of COVID-19 on maternal and child mortality in low and middle income countries is very concerning. We're seeing disruptions to routine immunization, family planning services, as well as to the general services that are provided to children who are sick and malnourished. This is affecting all children, including those that live with HIV. Now, moving on to something that we know much more closely, we need to consider the disruption that COVID has caused on the delivery of HIV services. And it's important that we try to understand what part of the continuum of care has been affected the most, whether countries have been affected differently, and if pregnant women and children have suffered most by these disruptions. We also need to investigate the mitigation strategies that have been employed, what worked, and what we can use for the future of the work that we need to do. So the first message that we got from a survey that was undertaken as soon as COVID started to hit low middle income countries is that HIV testing and viral load monitoring were the first to be disrupted. Initially, ART services didn't seem to be heavily affected, and the same was for SRH services, PMTCT, and EID. But then when we then started to dig deeper in the procurement issues, for example, we saw that 30 countries reported important challenges with ensuring supply of antiretrovirals since April. And that was because they were struggling to replenish their stocks when borders were being closed or air traffic significantly limited. These prompted efforts to try to estimate and project the impact that all of this might have on HIV programs. And modelers have explored a number of scenarios that all appear quite concerning in terms of additional deaths in people living with HIV, as well as in terms of new pediatric infections that are resulting from reduction in uptake of maternal testing and treatment. Now, this analysis was further expanded by John Stover and colleagues who looked at the 21 priority countries as a whole and modeled different scenarios of disruption. This work projected up to 86% increase in the number of new infections, which looks like more or less the number of new infections that we had 5 or 6 years ago. We then moved into considering gathering voices from the ground, from those of you that are working in HIV programs in various countries. And while important differences were noted, there are some common challenges that people reported, and in particular, the limited access to health facilities that mothers and children had, which obviously affected their services in particular. In some countries, we've seen that devices that were dedicated to the EID redirected to COVID testing, leading to stock out of lab commodities and important delays in turnaround time for EID and viral load monitoring. We also saw that the setup of new point of care sites were delayed, and all in all, countries confirmed that early signal that the most affected component of the HIV programs was HIV testing. We also heard of ARV stockouts that were indeed a problem, but those were resulting of an important transition that countries were undertaking towards more optimal regimens. And it appeared that those stockouts resolved over time. But one issue remained, and it was pretty common in many countries, the lack of nevirapine syrup that affected the way we were able to provide postnatal prophylaxis. We also know that as a result of all of this, a lot of children were not started on treatment as much as they should have, and the same was for women. And that the care of those that were already on ART was affected, obviously, by the limited capacity that healthcare workers had, particularly when some of them were redirected to COVID-related activities. We in WHO, as well as global partners such as UNICEF, try to really stress the importance of maintaining essential services where possible at the facility and where not possible through community-based services supported with protocols to guarantee COVID infection prevention and control measures. And beyond this, there are many solutions that countries have identified to mitigate the disruption and innovate service delivery. Our colleagues in UNICEF have put together this fantastic compendium that documents many of the strategies employed by countries, such as month-to-month dispensing for children and adolescents for 3 or 6 months, which is something that we hadn't really implemented as much before. There's also been use of community engagement to implement virtual and social distance activities and support adherence and retention more in general. Countries were able to prioritize strategies for treatment optimization and really be able to frequently monitor the stocks of ARVs. Virtual follow-up of ART clients was also put in place, as well as support to send reminders for EID appointments, for example. And efforts were put in place also to optimize the networks and guide prioritization of samples for EID and viral load monitoring. One example can be provided by the work done by Mothers to Mothers that have for many years been supporting mothers living with HIV in multiple countries. And as you can see, their activities have been adapted in the context of COVID to use virtual platform as much as possible so that mothers living with HIV and their babies can be supported through the community and in a safe manner. We've also seen the CATS model being adapted in Zimbabwe and beyond to include HIV testing so that adolescents at risk of having HIV could be identified and tested. CATS supported also multi-month dispensing and virtual case management through virtual platforms, phone calls, SMS, and WhatsApp. They also supported taking ART refill to the community and ensuring that viral load monitoring due was undertaken. They also engaged with virtual support groups that had material that was adapted to the development stage of the people involved in the groups. And not just that, but also continued that wonderful cross-country collaboration that it's really taking the CATS model to many countries where it's being adapted and adopted. And so training and mentorship was still possible through the virtual platforms with 8 partner countries. So it's clear that countries have really put in place a number of solutions and were able and demonstrated important resilience during these difficult times. And Mary has already showed you this slides that really point to the fact that in many countries, services may have gone back to where they were before COVID-19. And this is based on the information that we receive at the global level. And this is true for PMTCT as well as for EID. But it's clear that disruption happened, and the consequences of those disruptions is something that we need to bear, and we need to be able to respond to and catch up quickly. To do that, we really have to put the family at the center and be able to provide a package of care that goes from maternal testing and retesting, including offering of family planning services and SRH services. We need to make sure that we rapidly identified HIV infections in infants through the use of point-of-care testing, and that no one goes back home without an HIV test. We also need to start ART as soon as possible in those that are identified, and do that after assessing advanced HIV disease, providing screening, prevention, and treatment where needed, particularly in the context of rising levels of tuberculosis in many of the communities where we work. We also know that some of the patients have interrupted their treatment as a result of the stockouts. And so undertaking viral load monitoring promptly and providing adherence support will be very, very important. And that will include using point of care for viral load, for example, which will be able to, which will allow us to really act upon those results as quickly as possible. It's also not just about the virus. We need to think about nutrition, particularly in a context where the economic challenges will make very difficult for these families to provide to their children. And finally, but very importantly, the catch-up immunization. We know that a lot of the routine immunization has been disrupted, and I'm sure that many of you have read some of the estimated outbreaks that could happen, particularly with measles, if immunizations are not caught up. We know that all of this, to have a long-term success, needs to happen with a person-centered approach, with the right psychosocial interventions, providing psychosocial support, and including peers, particularly for adolescents. We also need to support healthcare workers. These colleagues were very busy before the COVID pandemic, and now more work and more emotions were added to their plate. We also know that vulnerabilities of adolescents will have to be considered and definitely not be left behind. Finally, I want to conclude by really acknowledging that COVID-19 has and continues to affect the way we provide HIV services in children, that there is more data that we need to collect, and we can do that all together. That there's been important disruptions on HIV services, and some of them have not been fully measured. And so it will be important to fully appreciate the impact of COVID on HIV services to be able to develop a tailored response in each country. We've seen also that a number of solutions have been put in place, and those solutions are not just important to recover, but also to potentially improve the quality of services in the future. And we need to do so by really placing the family at the center and be able to maximize that one opportunity to get in touch with the family at the facility and ensure that in that interaction, a full package of services is provided to them. And finally, but very importantly, the need for resources and political will. We need to make sure that in this crisis, children and adolescents are not left behind again. And I think that all of us in the pediatric HIV community can be strong advocates for that. And I hope we can all take this message loud and clear in our respective communities. So I'll stop there and thank you for listening. And I want to thank you. I want to thank also the colleagues that contributed to this presentation. And I wish you the best for the continuation of the workshop.